All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's episode is an opportunity to hear a personal story and for us all to reflect on some lessons learned from someone who is sitting on all the sides of the table as a cancer survivor, a family caregiver, and a palliative care social worker. Anne Front is our guest, and she is a palliative care social worker and a family therapist who works at the Motion Picture Television Fund, which partners with UCLA Palliative Care to provide outpatient community support. She's a writer of articles, ebooks, two chapters in the Oxford textbook of palliative social work, and has a TikTok channel for community education on palliative care under the name of the Palliative Therapist. And so our format today is that Anne and I will hold a little bit of a discussion for about 20 minutes or so. And of course, we'll save some time at the end for some questions. So with that, Anne, we want to thank you. And where do you think we should start?
Thank you for having me. Maybe I could just tell you a little bit about my background. I've been in the mental health field for years, but about 14 years in palliative care. And it was in 2019 when my husband was diagnosed with metastatic prostate cancer. So I went from being this know-it-all, how to work with serious illness to all of a sudden like, whoa, like this is pretty, tough stuff. So then I have my cat here, so I hope you guys can hear me. So then it was right around 2020. He ended up getting radiation. The last day of his treatment, he ended up, the city shut down because of COVID. And I had a senior in high school, a freshman in college. So their lives were completely disrupted. And we're in this house with, my father was here. It was the five of us just with this dark cloud, like you're going to die tomorrow. Like it wasn't about there's treatment options because I knew about palliative care. I knew about the ICU. So for me, it was just like the doctors say there's treatment, there's, opportunities, but it was like, no, you're going to die. So let's fix this. Mm-hmm. And my husband was sort of in that same kind of shock and grief state too. So we get through COVID. The kids, we're dealing with all the stress of that. And then 2021 hits. And so I said, well, I got to start going back and get my colonoscopy, get all these things that the doctor's telling me what to do. I didn't do the cardiac test. I'm not going to do the treadmill, but I did my mammogram and I thought this is just a usual thing. And they called me back and I ended up having breast cancer. So I caught it very early and it was a lumpectomy followed by radiation. I didn't need chemotherapy. So my husband was diagnosed. I'm going through, all the COVID stress of the kids losing their senior and freshman year. And then just when we're getting back to normal, I have cancer. And so it just like broke me down because, it was like my world. I'm trying not to disrupt my children. And, I don't want my husband to die. I don't want both of us to die, even though we weren't. So it was just very stressful. So it was then that I started kind of looking at palliative care differently because there was just so much learning that I had, so much about, how to talk to patients, how to be with families. But I'm a social worker and I never realized how emotional the journey was. It was just, I don't know, it was like, it's good to talk about these things, but to actually feel them. And what I realized is that I was going through this huge grief experience where I was grieving the life that I had. I was grieving the future that was coming. I was seeing myself as a widow and how to plan for the future. And then when the doctors are telling me things, it was just like, I can't even process. I remember when I got my lumpectomy, I came out in the waiting area, and I'm coming out of the anesthesia or whatever. And the nurse is saying, how do you feel? What level pain, 1 to 10? And I just couldn't stop crying. She's like, you have to give me a number. And I'm like, I don't like, what's the number of the tragedy that I feel? What's the number of the physical pain? So I just like, just couldn't speak. And then she finally said, well, you look pretty bad. I'll give you medication. So, but it was just like nobody that I've worked with, I've never experienced that where I've just been like, let's plug along with my agenda we really need to get what the goals are. We need to figure out what you need rather than like, let's stop and like, why are you crying like a mad woman? Like what, let's start there as a person that you're in a lot of pain and even just validating like you're crying, what's going on? Like hold my hand. And so those personal moments that I got from my providers and caregivers just meant the world to me. Like I will never forget the nurses and the doctors that held my hand and said it's going to be okay. And I think now with the patients that I work with, that it always starts with the emotions, that if I'm not treating the emotion in the room, then they're not going to hear a word I'm saying. So that's kind of where I came emotionally. And then the other part was with palliative care, we talk so much about paternalism, that the patient is the captain of their ship and they're the one in charge. And I was like, I don't want to be in charge. I don't want to die. I don't want my husband to die. And so it was really like, maybe it's okay that the doctors are in charge sometimes, or the palliative care team, like we need that guidance. And so it's not that you're making the ultimate decision for me, but I can have your guidance. Like, what would you do?
Mm.
It's okay to cross that line a little bit. Like, this is what I would do, but it's your life too. And to have more information, like, you have stage 1 breast cancer, you're probably not going to die. So radiation or chemo or whatever you need, may be a good thing to get back to where you're at. Or with my husband, it's a lot worse because he has it in his lungs, he has it in his bones. And so it's a whole different story, but we really need that guidance sometimes. And then the other part is just I think you and I kind of talked about the language of palliative care. We talk about metaphor and, how with patients, when we say, let's fight this, a lot of times, at least what I've learned with palliative care, it's like, well, it's fighting the right thing, because with my husband, he's not going to win in terms of, cure or miracles or anything. So what does fighting mean? And for him, he's always had this really positive attitude. Like, I will get through this, not physically recover, but I will maintain my sense of self, my sense of who I am. And that's what I'm fighting for. And so removing that sort of metaphor for him was like, I need every ounce of energy and whatever bring to the table to maintain this. And that was what was important to me. Where for me, I agree. I'm not a fighter. If I was bullied in school, I would just be bullied and let people walk all over me. So that didn't work for me. And I needed a different approach. But I think it really was about listening to the person. So that's kind of where I come from. And I sort of see, we talk about being lifelong learners. And I think using our experiences to learn from each other, to learn from ourselves, but also realizing that you're dealing with a person here, and all the platitudes or, take one day at a time or stay in the present. It's like, I don't want to stay in the present. My head is like going 10 steps ahead. So listen to that. And then, then we'll go from there, getting to know who the person is and where they're at.
Wow, I've got so many questions.
I know I talked really fast. My whole life in 10 minutes.
Let me share one of the comments, and then I'll ask you a follow-up question. So Elizabeth here says, I prefer the term parentalism rather than paternalism, in recognition that there are many female, I'm just going to say clinicians now, just a tiny way to be more inclusive, even if it's a term that's a bit of a negative connotation. I like that.
I went to a lecture about maternalism, which I really liked, as opposed to paternalism, or, and there is that gender classification that I should talk, but bringing in that father and the mother part, I think, because the mother traditionally is sort of more, nurturing and things, and we're all part of that. But I like that. I like that a lot.
So you said you mentioned it's going to be okay. I don't know. Tell us a little bit more about that, because the longer I practice palliative care, the more I try to focus on be positive, no matter how how gloomy the situation might be and how important that is, and leaving the room with something that seems hopeful in some way.
Yeah. I think what being okay to me is that never losing your sense of self, that, we all on this screen are seeing people die frequently and it's going to happen. But my wish for patients is that they never die outside of who they are, that it is on their terms, and that to the best of my ability to help people have a sense of peace around where they're at. And as people are in the dying process, usually if they have a serious illness, they have a little bit of time to kind of say what they need to say. Not always, but I really want to focus on that whatever your body is, it's not about being okay in terms of cure or getting through this. It's more like, this is sort of the lot, that was given to me, the lottery card. And so how do we make the best of it in this really hard situation?
Did they use that term? It's going to be okay. And if they did that feel okay with you?
I
I've
don't know
never
if
tried.
anybody's,
Yeah,
I don't know if
sure.
anybody said that to me.
Mm,
I think that would be kind of invalidating because
okay.
a lot of my patients, they don't feel okay.
All right.
One thing I heard from my oncologist was it's a blip on your screen. You're going through this, you're going to forget about it. You'll live years and years, and you'll die of something else. So don't worry about it. I was like, well, it's not a blip on the screen to me, and so it was kind of really taking in the magnitude that I wasn't dying, but in the moment I felt like I was. So how to, I guess the goal is not to say you're going to be okay, but to help provide that nurturing and the care, that we've got you, we're walking this with you, you're not alone.
The Circling back to your comment on autonomy, quite a few times now I have met with patients and family that have shared that they feel, they don't use this term, but they feel that they are abandoned to their autonomy,
Yeah.
which is a term you'll sometimes find in like the ethics literature. And it's almost like, here are all these options. What would you like? Is And that's something I you have experienced in some way. It didn't feel guided.
Right. Yeah, with my husband, there's been different things as he's going along, like the clinical trials are now standardized. So we went from only radiation to probably radiation and chemo to now there's a new treatment, this liquid radiation that helps with prostate cancer. And there's just like all this growing stuff. And they're like, well, it's all on the table and your medications aren't really working anymore, but we'll try a new medication. And well, what would you do? Well, there's these choices. We could pull the trigger at any time. You could start chemo tomorrow. You could start Pluvicto tomorrow, or you could stay, try this new medicine and we'll figure it out in 3 months. And it's like, I don't know what to do. Like, we want to live. We want him to not be in pain. So what would you do? But it's, understandably, it's the doctor isn't going to take responsibility for, you do this and there's worse outcome. But at the same time, having a little bit of guidance and humanism. One of his oncologists, his father is going through this and he's tried the Pluvicto. And so that it's like, that's very humanizing. Like, okay, you understand what it's like to go through this. And so you've been through the decision making, and that support is really helpful versus sort of a more clinical approach.
Yeah. There's another comment in the chat. Steve says regarding the statement of you're going to be okay, that he prefers to focus on non-abandonment, like saying something like, I'm sorry that you're going through this, and we're going to do our best to try to help.
Yeah, yeah. I say to a lot of patients, that we're here. We're not going anywhere, And I work on an outpatient, so I have a longer relationship. We'll work, before and during and after hospitalization, so it makes it a little bit easier. But even in the moment for when I worked inpatient, it was like, I'm down the hall, I will come back up. I will support you. And that just, even if it's just my colleague will support you, just knowing that there's a team there that is, they're not going to abandon you.
Yeah.
They sort of anchor you.
There are a couple more comments. I want to ask one question and then we'll get to a few more of the comments. I want to hear more about reframing the fight metaphor. I Earlier on in my career, I tried to help patients reframe the fight metaphor, I think erroneously, by sharing what I thought they should fight for, which came from a good place, right? I think initially when you're early on, that's what you do. And I feel like I have learned that how could I possibly have the audacity to reframe someone else's hope based on what I think they should fight for? I'd love to hear a little bit about how you think to appropriately reframe someone's hope, how to help draw out from them what it is that they truly want to fight for.
Well, one of the questions our chaplain says a lot is, what are you hoping for? So it opens up the question where I don't think a lot of, regular doctors outside of the palliative care team even think about that, because if we come in and say, do you want to know your prognosis? Here it is. But saying, what do you hope for? And a lot of times I hear, I hope for more time, or I hope, that my body, I'm not going to be in pain. And then I'm seeing the wife or the husband or the partner next to them and they're sobbing or, trying to keep it together. And sometimes I've said, what do you hope for your family? And then they break down so often that I'm really not worried about myself. I want my family to be able to manage after I'm gone. I want to be able to tell them how to survive. And so it completely changes the subject, where it's really taking in the whole family, but also you're the patient's the starting point. And so whether you use the words fighting or something else, it's about what's your language and kind of looking at the body language around you, that what's on your mind.
Yeah. Like using motivational interview techniques, right? To sort of draw out some of that instead of saying something like, but wouldn't you rather fight for, ooh, because I
Yeah.
mean, we
Yeah.
fall into that trap, I think, early on. Wouldn't you
Yeah.
rather? Wouldn't you? Yeah. So,
Yeah. I liked Dr. Steve Pantalot once said I was talking to him and he said, ask the patient directly, what are you anxious about? Like as if you're already saying we have space for whatever worries you have. And some people say, I'm not anxious at all. I'm just blah, blah, blah. And other people will say, oh, I can talk about my worries. I can talk about feelings. It sets a different tone and different things come out where when we're talking, we're not getting the same conversation. The listening is where you get the meat of what the needs are.
another question in the comments section. So Eve says or asks, what interaction with the care team with you and your husband has been the most beneficial, maybe to the point of changing how you approach your own patients and families?
Well, I guess that's a great question. I guess the good parts and the bad parts. The parts for me when I felt invalidated, when and not really from the palliative care team. My husband has the palliative care team. I don't. But feeling like you're talking to me as a clinician, you're being very scientific about what the options are, what the needs are, how the medication is, what are the side effects, and not really seeing me as a person. Because I was coming in with cancer with a pretty, positive outcome, but I was also carrying the prognosis of my husband, of the kids that had this, all this trauma. And so I wasn't, your patient coming in with one single issue. And it was learning that there's so much heavy emotion that when the providers or the team wasn't treating the emotions, then I was just shutting down. And for my husband, I think what we've learned is just really that giving time, and it's not always easy to have time, but to the best of the team's ability to just say what is important to you, what are you hoping for, and what are the issues that are coming up today for you in your life, so that we're not just leading on, what's your pain from 1 to 10, or are you having bowel issues? Those things are important, but there might be other things going on in the room.
It's, and I know you and I were talking about this before we started, but I want to bring it up again. I have met some of my own colleagues that have had their own serious health, which fortunately I have not yet. And I have seen how overnight that changes them. And all the things you mentioned, right? You know that people can be consumed by emotions, and you were.
Mhm.
And all these tropes that people will say about, grief and other things. I worry that there's so much that we don't know that are blind spots to those of us that have not lived this firsthand. Is I don't know how we can be better at recognizing these blind spots without actually having an illness. I mean, we can hear you, but are
Mhm.
we really hearing you? I don't
Yeah.
know.
Yeah. I think for me, what I've learned is the sort of the platitudes that I give. Like it's so common on my team for us to say, let's just take one day at a time. Let's not project into the future that you're worried, and you're worried that your husband's going to die, but he's not dying now. He's here, let's be present with that. And it's like, I don't know if I'm going to be able to pay my bills if he dies,
Hmm.
and he's thinking, I don't know if I can work if I'm so much pain or bedridden, and if I'm not working, that's such an important part of my identity, then what happens there? So it's like when you say, let's stay present, it's like, I don't want to stay present. I want to plan for the future. And so until we got to a place that things are settling down, we've done the work we need to do. And it's like, yeah, now we need to sit with it. But when I hear my team now say things like that, I just want to roll my eyes, because it's like, what does the patient need? And I think it always starts with the listening first. So regardless if we were in that situation or not, really trying to understand them in their language and in their emotional state.
Hmm. Do you interact differently with your husband's palliative care team?
It's mostly the doctor. And so, yes. And it's one thing that's really hard for me is that, as I'm sort of a control freak. I know how things are going to progress, even though I'm thinking, you're going to go in ICU and be on a ventilator.
Hmm.
That's that. And he probably never will. So I want to know the prognosis. I want to know what happens next. I want to know if things get worse, what does that look like? And he doesn't want to know those things. And so it's that balance of how do I sit back and say, as much as I want to, he's the patient and he's the one that calls the shots. So, yeah, just having respect, I guess.
Hmm. Hmm. All right, let me see. There are a few more comments here. So Sarah says, in regards to staying in the present, I like to ask patients how far into the future they want to look. Sometimes people want to prepare for all the possibilities.
I
Some
love
do
that.
not.
I love that. I'm going to use that.
Do you wish the palliative care team would then just treat you guys differently? Say, I I hear you, Mr. Front, you do not want to talk about these things. I know
Mhm.
that Anne, you do. Maybe we could just meet with Anne and start to prepare.
Mhm. Yeah, I think that would be great. And we haven't got to the point where it's so bad where I've been able
Hmm.
to say, maybe my issues, knowing what I know at work, I need to let that sit back. There'll be a time where I do need to do more, so it's regulating my own. But as with patients and families, we've talked about doing that, and that's been extremely helpful for them.
One of the elephants in the room in the hospital world is always code status. Code status comes up
Mhm.
over and over. Did you talk to them about being DNR? Have people done any of that with you or your husband, how does it feel on the other side?
I think it's with my husband mostly. I think it's very relieving, and also for him that there is that line in the sand. It's very concrete. It's very clear. We've been told we're not there. We're not close to being there. In the hospital, you are there.
Hmm.
But it's going back to we're preparing for the worst case scenario. And it's like, okay, I can get my head around that. If you say, you're not paying your mortgage and you're going to lose your house at some point, at what time, do you want to talk about that? Then that's pretty concrete. And I think we can handle that. But it's in that context of, again, you're not alone in making these decisions, and these are hard decisions. And for us, when we knew what his code status was, we talked about that it will change, as things progress. We'll have different, understandings or whatever. And it's like, okay, well, that makes sense. And I can, buy that. And even in the hospital, I think having that at this moment, let's just let the DNR discussion sit. You want, some form of full code or selective treatment. We're gonna come back a few hours later and see how he's doing, or we're gonna come back tomorrow. And so it becomes a conversation rather than you need to figure this out now.
Hmm. Yeah, lovely. We are almost at time. And I don't see any more questions or comments. Maybe you could leave us with one last final piece of wisdom or advice, something that you've experienced.
I think what is most important to me, and I think to my husband, is we do not want to lose our sense of self, and remembering always, and I know everybody here knows it, but it's the person first, the patient second, and always, no matter how dire the circumstances are, just realizing that let's always go back to who you are as a person, that every decision you're making, it's not clinical, it's out of the love for yourself, for your family, what you want. And I think it starts with that.
Is there a certain way you like to ask about who they are as a person? Because I think we in palliative care love phrases or questions that we can use. Like, what are some of the words you would like to ask people to get to that sense of self?
I think asking things like, tell me about yourself, or, what did you do for a living? Or, how many kids do you have? Or when a lot of times our work is dealing with families. So who were they like? Like what makes them laugh? Or, what gets them up in the morning? And, what are their hobbies? And just, even if it's just, you have 5 minutes for that, those little things really matter.
Yeah. All right. Anne, we appreciate your time with us today. Thanks for sharing your story.
Thanks for having me.
Absolutely. All right, everybody. Have a lovely weekend.
Bye bye.
Bye.